When I meet a patient for the first time, the most common question I get is, am I going to live or die? I mean, the word leukemia sounds very scary, and it should be. I mean, there are some forms of leukemia that are still very, very virulent. Fortunately, in the last 20 years, we've done very well against chronic myeloid leukemia, or CML, and most patients, and I don't mean just 51%, I'm talking 90% or more of our patients are going to do very well and have normal lifespans. I think that's the most reassuring thing that I can tell a patient who's brand new diagnosed, is that by taking one of these pills, the so-called tyrosine kinase inhibitors, the chance of them living 10, 20, 30 years is quite good. So I try to reassure them that this is not the other types of leukemia that they may have heard about or be scared about. They do need to take their pills, and so I really do emphasize that this is a serious disease. But I think that that's the most common question I get in the beginning. The second questions I get after they started the pills are, what are going to be my side effects? And I think the most important thing I tell the patients there is, talk to me. These are chronic medications. You're going to be on them for many, many years. So talk to your doctor, talk to your nurses, and tell them what you're having, because there are a lot of little tricks. For example, muscle cramps, which is very common, taking some Tums, some calcium pills, or taking some tonic water, Schweppes brand tonic water that says quinine on it. The simple things that you can get in every supermarket. These type of things can really make a big difference in how the quality of life is. But if I don't know the person's having muscle cramps, I'm not going to tell them to take tonic water at bedtime. And so there's lots of little, what I call nuisance-y type side effects that may not be little if they go on month after month, year after year. So talk to the doctors and tell them what you're having, and then we can see if we can modify the dose or have some little trick. The third question I get after a little bit of time is, am I doing well? And the answer to that question is to look at your PCR monitoring. I think there's a common mistake by family doctors, by people who don't treat CML a lot, and often by patients, that they look at the blood counts, which they can get as soon as they go into the doctor's office, and the blood counts are better, and they think, oh, I'm doing good. And unfortunately, the blood counts don't tell the story. There can be people who die despite having normal blood counts. So the monitoring is done by a PCR, or a blood test, that specifically looks for the Philadelphia chromosome gene protein, something called the PCR for BCR-ABL. It's a common test. You'll see it on the bill. It runs around a couple $100. So all of a sudden you look at your doctor's bills, and there was a little spike that they did a more expensive test. You know your doctors may be doing it. But it's the type of question that I should be asked by the patients, or I should be telling the patients, hey, this is your PCR test. And PCR tests are done at 3 months, 6 months, 9 months, a year. And from that, we can tell if the patient's really responding to the therapy. If that PCR is going down, the leukemia is under control. And so that's a common question I get 3 months into the therapy or 6 months into therapy is, am I doing well? And here's how I can answer it. And then the last question I get that's popping up now for patients who've been on therapy for many, many years is, can I stop? And I think that maybe 5, 10 years ago I would have told them, no, you're going to be on this medicine forever, but you're going to live for a long, long time. Now I can say, wait a minute, you've done very, very well by your PCR studies. I can't find any cancer cells, and I haven't been able to find cancer cells for the last couple of years. Maybe we can stop drug. But if we do that, we're doing it sort of on a researchy type area. There is data from France, from Australia, from Europe, and there's emerging data from the United States saying that maybe 40, 50% of patients who've been in deep remissions, and they've been in deep remissions for many years, that about 40 to 50% of them can come off medicines. So it's a small subset of patients, but there are some patients that can come off medicines. That's one where we have a long discussion about the pros and cons. It is taking a little bit of a risk, but it's something that we can sort of address with individual patients who have done very well, and maybe patients who are having those chronic nuisances, side effects that don't go away, where it might be beneficial to try giving them a break and seeing what happens.